احنا طبعا كعاده دكتوره وسام وكعاده البرنامج بيبدا طبعا بشكر كبير جدا لدكتوره وسام. دكتوره وسام صححت لي معلومه، انا كنت بقول ان هي ريبريزنتيف لمصر في الاي اس ان كنفروباثولوجيست. هي مش ريبريزنتيف، ده هي يعني حاجه عظيمه جدا تستحق طبعا ان احنا نفتخر. هي الديبيوتي للكوميتي بتاع النفروباثولوجي، هتصح تقول بالظبط هي الدور بتاعها ايه، لكن اللي نعرفه ان هي هتبقى فوجو احنا بنعرف الدكتوره فوجو من كتاب الباثولوجي، فاذا كانت هي هتبقى مكان فوجو نفس المكانه ونفس فتبقى اكيد حاجه عظيمه ان شاء الله.
الله يخليك.
والشخص عظيم بافعاله دكتوره وسام. احنا today we are going to hear from you one of the most important and exciting topics in nephropathology. Usually we have a lot of mess in this issue, which is monoclonal gammopathy. I'm sure that you will clarify this topic very much. دكتور وسام.
I hope so. Thank you very much دكتور حسين. ويعني طبعا أنا I welcome everyone. It's always nice to meet you. احنا زي ما قلت قبل كده ان احنا الاول ابتدينا بالseparate glomerular diseases بالindividual entities، وبعد كده ابتدينا بالsystemic diseases which can cause several forms of glomerular and tubulointerstitial injury within the kidney. والمره اللي فاتت خدنا lupus nephritis، والنهارده زي ما الدكتور حسين قال هناخد a very messy and difficult topic I know, which is renal involvement in monoclonal gammopathies. I'm going to talk very basic. The target is that you understand what we mean by monoclonal gammopathy and the wide variation we can see in renal diseases regarding this entity. Okay, monoclonal gammopathies, you can say this is the recent term or the more widely used term now, referring to what we used to call plasma cell dyscrasia, paraproteinemia, or dysproteinemia. They all mean the same thing. This could be a more sophisticated term, but actually because not all of these patients have this form of dysproteinemia or paraproteinemia, as we're going to discuss. So monoclonal gammopathies are a heterogeneous group of disorders which is characterized by clonal proliferation of B lymphocytes or plasma cells. Producing this clone, this B cell clone or plasma cell clone, produces a monoclonal immunoglobulin. And this monoclonal immunoglobulin is what we refer to clinically or serologically as an M protein. And it's associated with a wide spectrum of both malignant and benign conditions. In those patients, in this group of patients with monoclonal gammopathies, symptoms do not only develop because these patients has malignant transformation, but they develop also due to the properties of the secreted monoclonal immunoglobulin itself. And this is a very important point to understand. So the disease is not because of the malignant transformation these patients could have, it is rather due to the properties of these secreted monoclonal immunoglobulins. And hence, these patients has variable and diverse renal diseases. All of these group of diseases we group under this term, which is monoclonal gammopathies. Most of them, most and not all, result from the deposition of intact or altered monoclonal paraproteins within the renal parenchyma. So that means that it's usually characterized by a single light chain restriction, kappa or lambda, with or without a single heavy chain, mostly IgG. Let me remind you, this is our antibody and we are going to see it again. And this is the constant regions. Here are the variable regions. We have the heavy chain and we have the light chain. So either we have the light chain or the heavy chain, as I'm going to discuss. This is what we call monoclonality. We don't have a regular complete immunoglobulin. Much less commonly, these diseases has been reported without actual accumulation of the paraprotein or a derivative of it within the kidney, what we call could be related to dysregulation of the alternative pathway of complement, and we're going to discuss this. Okay, what do we mean by monoclonal deposits? What type of deposits do we have basically in the kidney? In our regular scenario, we have polyclonal deposits. That means we have heavy chains, either IgG, IgM, and or IgA, depending on the disease, plus both light chains, the kappa and lambda, because this is a normal immunoglobulin, plus or minus C3. So this is our normal scenario. These are patients who have what we call polyclonal deposits. So one immunoglobulin and both light chains. Both light chains has to be present. So you have to detect kappa and lambda, but with variable intensity. We already know that they have a ratio, and in general, kappa is more than lambda, so the intensity of their presence in the kidney also varies. But at the end of the day, in a polyclonal deposit, this is what you see. You get to see all of this, both light chains. What about monoclonal deposits? We have so many types of monoclonal deposits. The first one are light chain deposits. That means we have only a light chain without heavy chain. So without IgG or IgA or IgM. This light chain could be kappa or lambda. So what we detect is only the light chain. No immunoglobulin, no heavy chain, and no C3. So we call this light chain deposits. The second scenario is that I get only heavy chain deposits. I get an immunoglobulin without a light chain. So I get either IgG, which is much more common. Rarely we get IgM, no IgA, no kappa and lambda, no C3. So you only detect an immunoglobulin without its light chains. So this is also abnormal, because the normal is that if I'm going to detect IgG, I have to have kappa and lambda with it. But in this scenario, no free light chains, no C3 deposits, only the heavy chains. So no light chains, meaning no kappa or lambda, no C3. The third scenario is that I'll get one of the immunoglobulins, usually IgG or IgM, plus only kappa, a single light chain, which is kappa. It's not lambda plus C3. So in this scenario, kappa, and I have C3. What am I missing? I don't have a lambda chain. So this is also monoclonality. For example, we have IgG, we have IgG, kappa, and C3, or IgM, like in proliferative glomerulonephritis, or IgM, kappa, and C3, like in cryoglobulinemia, for example, and no lambda deposits. So again, this is monoclonal. The fourth scenario is that I don't have any heavy chains at all. I only have C3 deposits plus one light chain, either kappa or lambda. C3, no IGs, one light chain, kappa or lambda. So this is, in this case, we have C3 deposits with single light chain, the other is absent. So what we call light chain deposition disease is kappa or lambda without heavy chain. What we call heavy chain deposition disease is that we have the heavy chain, we have the immunoglobulin without any light chain. So these two are opposite to each other. We have only the IgG without light chains. And in both scenarios, we don't have C3 because we don't have an immune complex mediated process. In the third scenario, we have an immune complex mediated process. We have an immunoglobulin, which is G or M, but we have only kappa light chain. We don't have lambda, and this is why we call it monoclonal, because if it's polyclonal, then like the first example, I have to have the kappa and lambda. So I call this GN with monoclonal deposits, whatever the type of glomerulonephritis, as we're going to discuss tonight. And the fourth scenario is that we have no heavy chains at all, no immunoglobulins. We only have C3, like in C3 glomerulonephritis, and again with light chain restriction, either kappa or lambda. And so this is a C3GN with monoclonal deposits. There is a fifth scenario, but really it's extremely rare. It's even more rare than the heavy chain, the isolated heavy chain deposition disease, where you can have both. You can have light chain and heavy chain deposition disease, and this occurs only in only few diseases of the spectrum, as we're going to discuss. So these are the types of deposits, and all of this list is what we mean by monoclonal deposits. We know that we have common entities in what we consider renal involvement in monoclonal gammopathies, like amyloidosis, like monoclonal immunoglobulin deposition disease, what we call MIDD, whether it's light chain, whether it's light chain and heavy chain, or heavy chain. And we know light chain causes nephropathy, which is myeloma kidney. These are the ones which are familiar, and these are the ones actually which are relatively common that we see in the majority of our patients. However, we also have to know that there are relatively new and less common entities, because we can also see them in our patients, like proximal tubulopathy with or without Fanconi syndrome, like proliferative GN with monoclonal IgG deposits, like when we organize deposits, glomerulonephritis, like type 1 cryoglobulinemia, fibrillary and immunotoxoid, like membranous GN, like thrombotic microangiopathy, like C3 glomerulonephritis, and so on. And hopefully we're going to cover all tonight. So we do have the ones we know, which are the common ones. Again, I'm stressing that these are the common ones, but you also have to know the other ones. Less common does not equal rare, and does not mean that you're not going to see a patient with them. Why do we have such a wide range of clinical and pathologic heterogeneity in these patients? It's not only a different morphology, but as we agreed, a different morphology is going to lead to a different clinical presentation. Is this because we have an abnormal host response, so we are individualized, each one of us respond differently to these light chains, or is it the properties of these abnormal proteins in themselves? Actually, studies had showed that it's not our response. These are the properties of the abnormal light or heavy chains, rather than our response that determines the nature of the tissue damage. So we cannot predict. These light or heavy chains have different physiochemical properties. They could be abnormal in so many forms. They could be large in size. They could be numerous, so they get deposited. But more importantly, they can also be mutated and altered light, which makes them quite difficult for detection, both at the serum level as well as the tissue level. Because, and I'm going to repeat this again, but I'm saying it now, the kits we use, whether in serum or in tissue, are only for normal structures, for normal light chain and heavy chain. If the problem is going to be with altered ones, it's going to be very difficult to detect them. These chemical properties depend on a lot of things: size, glycosylation, concentration, their titer, as I'm saying. The more they are, the more florid, you're going to see them everywhere. The resistance to proteolysis inside the cells, whether they bind to Tam-Horsfall protein in the kidney or not, and their tendency to bind the tissue and where to bind them, as I'm going to explain. And hence, all of this is going to dictate how they're going to precipitate. So not only where, but where and how. Whether these light chains are going to be granular, are they going to be fibrillar, are they going to be tubular or crystalline. And because of this, you all know this table, that we mainly classify them into amyloidogenic or amyloid deposits or non-amyloid monoclonal deposits. So these deposits could be tubulopathic and or glomerulopathic or amyloidogenic, can involve more than one compartment of the kidney. They don't have to come targeting a single compartment. So they can affect glomeruli, tubulointerstitium, and vessels, and can occur concurrently, meaning that they can occur together. What does this mean? We're saying that each light chain has a special physiochemical property. True, but we're not saying that all the light chains we're going to generate are all going to be the same. So we can generate light chains which are tubulopathic, and then generate light chains which are amyloidogenic, and hence the patient can present with concurrent manifestations of the monoclonal gammopathy he has. We can have cast nephropathy and MIDD, or MIDD and amyloid, or cast nephropathy and amyloid, and so on. This is a 58-year-old female who was referred to the hospital with acute renal failure. Her serum creat was 19.7, hemoglobin 8.4, her platelets were a bit low, 106, and TLC was 5.6. The patient gave a 1-month history of diarrhea, vomiting, and fatigability of gradual onset and progressive course. Her urine output decreased markedly over the last 2 days prior to her admission. She's hypertensive and controlled on amlodipine. She's a known stone former who needed twice cystourethrolephiotomy and as well once over the last 15 years. Her sonography showed the right kidney 13.8, left kidney 9.1 by 4.8, with small lower calyx stone, 0.4 centimeter, but no back pressure, grade 1 echogenicity. I remember this patient very well because this patient was completely a surprise finding to the clinicians, because this patient was just classified as end-stage renal disease, and most of the nephrologists did not want to biopsy her because of her history of stones, and that because she's a known hypertensive. And at the end, they reached the consensus just to confirm that she's end-stage renal disease. Let me show you her biopsy. This was her biopsy. She was very acute. She had absolutely no chronic changes, and she had these casts. These casts were fractured casts and surrounded by a cellular reaction. This is a classic multiple myeloma cast. This patient, Allah yarhamha, she had multiple myeloma. Her bone marrow showed, I think, more than 40% infiltrate. However, and remember my words when we get to the end of this talk, this patient had recovered her renal functions and died 2 years later with a different cause than renal failure. She died with a different complication of her multiple myeloma than renal failure. So this is cast nephropathy or myeloma kidney. Cast nephropathy or myeloma kidney means that we have abnormal or monoclonal light chain containing tubular casts with characteristic staining.
Dr. Wesam, excuse me, this is the very challenging case because we have a relatively small kidney, and the other kidney is, we consider it good.
I think the small kidney is the one which had the stone. Yeah.
Wanted to do biopsy, we'll do biopsy from the preserved sized kidney. So this is, all of us are afraid to do biopsy for this case, but it opened our mind for the differential diagnosis. If we have a case of renal failure, we should master the differential diagnosis by ordering laboratory parameters. And if we don't think of the etiology, we will not reach it. Dr. Adam would want to comment. Tfaddal ya Basha.
Yes, please. I must emphasize that you must biopsy any patient if you don't have a conclusive evidence of the diagnosis. And this patient has got 2 pathologies. One may be pyelonephritic kidney because of the stone, but the other is slightly higher in size, 13.8, which is justifying that it is maybe paraproteinemia or multiple myeloma, and it must be biopsied. We are afraid of biopsy as one single kidney, but we are not afraid of biopsy a transplanted kidney. So this is a bizarre. So
okay. Regarding this point, Dr. Ahmed, if we are thinking of solitary kidney, we should take it serious. It is not an absolute contraindication for biopsy. If the etiology is not clear, a biopsy should be done, and should be done in a facility that respects solidarity of the kidney, because we may induce catastrophic end of the kidney. There is a dogma that CT guided biopsy may be safer, and this is completely wrong, because ultrasound is a live technique. So I agree with you 100%. If the cause of acute renal failure is ambiguous and we don't know exactly the cause of renal failure, the ultimate is to do biopsy, ultimate destination to know the pathology and where we are. and because this will refine our management. But if we find a case like this, long-standing hypertension, stones, pyelonephritis, complete discrepancies of the cell of the kidney, if I don't put the diagnosis in my mind, I may miss it.
Yeah, but you got an unequal size of both kidneys, so you do have different pathologies. Yeah.
Yes, yes. Dr. Wesam presented the case in a very brief, because I think there was lab parameter, ultrasound, Doppler, everything, but it is a very nice case.
It sends, as you say, it sends us all, not only you, the pathologists, and all of us, a very important message. Be careful with the diagnosis of end-stage renal disease. Just don't base it on history. Irregular cast, your routine cast nephropathy or myeloma kidney can come with acute renal failure as a first manifestation. Remember that these patients' classic presentation is precipitated by dehydration, by infections, by medications, especially non-steroidals and diuretics. So always bear, this is what we call the classic combination of a patient who had a history of dehydration. We've seen a lot of patients راجعين من العمرة ومن الحج في الأوقات الصيف بالذات, they were precipitated by dehydration or had a history of infections if they are diabetics or they are on diuretics, or typical, of course, the commonest are non-steroidals. So again, this also is important because you always attribute the acute renal failure to the non-steroidals when this non-steroidals precipitate cast deposits. Then patients can also come with chronic renal failure with the full-blown features of chronic renal failure. And you would have proteinuria if we have a coexisting other monoclonal gammopathy feature like light chain deposits or amyloidosis, or if it's superimposed on other pathology, if this patient developed cast nephropathy and they are originally diabetic or originally hypertensive, or whatever they have. But the casts itself can also cause proteinuria. And this is again important. You're not going, this is the discrepancy between the proteinuria and the lack of albuminuria, and you're not going to find a low serum albumin and so on. And most of these patients have underlying multiple myeloma. Logically wise, cast nephropathies or casts are mainly from distal tubules. In advanced lesions, if it's a florid lesion, then the light microscopy is really diagnostic. You don't need anything else. The casts are usually weakly positive. You get variable-sized casts. They are fractured. They have angulated borders. They're usually multi-layered. They could be needle-shaped, as I'm going to show you, and they are surrounded by cellular reaction. This reaction is formed either of tubular cells, inflammatory cells, or giant cells, and they can entangle calcium oxalate crystals. The ones highlighted in orange are actually pathognomonic. So if I have a cast with a needle shape like, this is pathognomonic, this is light chain. If I have a cast which is surrounded by giant cells or which is positive for Congo red, this is pathognomonic, and usually entangling calcium oxalate crystals, they are highly suspicious. So this is your textbook cast nephropathy. You have a lot of weak stained casts. You have a lot of reaction, cellular reaction around it, basically tubular cells and some giant cells. Why do we have this cellular reaction? Because the light chains are irritating to the tubular cells. So the tubular cells form a layer around them, and I'm going to explain later why we also have an inflammatory cell reaction, and you have a giant cell here, a typical fractured cast here. Again, casts can take so many shapes and morphology. You can see here that they are around it. You have a florid inflammatory cell reaction surrounded. Look at this one. This is PES, and were absolutely PES negative. However, they can come in different degrees. These ones were PES positive. And you can see how here they were fractured and again surrounded, and a normal glomerulus. Here again a cast with a cellular reaction. Look at this one. This is a different cellular reaction with a different looking cast, and this is what we mean by a needle-shaped cost, you can see actually the cost can simulate the shape of the light chain crystals. As I'm going, it's actually crystals, needle shaped, and this how light chain crystals look like in electron microscopy. See, they are identical. So actually you can see the light chains sometimes simulated within the cost, and this is pathognomonic. Look again at this cost. Of course, these are all advanced cases, really florid myeloma patients. And you can see here, again, the crystals, how they look. Compare them to how actually light chain crystals look, and you find them identical. And look at this one as well. This cost also is formed of crystals. As I said, the presence of a giant cell in a cost is pathognomonic as well for a light chain cost. So in distal tube get in the lead, and then it's released into its free form, and you know this stuff better than me. And then you have the filtration of the free light chains. The free light chains actually bind to the uromodulin.
Dr.
Uromodulin has a special characteristic. Yes.
Regarding the hematoxylin and the bus stain.
Yes.
Does the discrimination between hematoxylin and because you didn't put it in as pathognomonic. يعني انا كنت متخيل ان لو ويك باس ستين وسترونج هيماتوكسيلين ايوسين.
No. No.
It doesn't discriminate cast from non-specific cast.
Yes, no, it doesn't. It makes you suspicious.
Yes.
It's highly suspicious, but it's not pathognomonic.
Okay.
Okay. As I said, uromodulin then has the capacity to form a gel-like structure, and this gel-like then starts to entangle the free light chains, and this what can also simulate the facilitates the formation of the costs. And with this increased pressure, there is basement membrane breach, leak of contents of the uromodulin together with the free light chains, and so you can get an interstitial inflammatory cell infiltrate. Eventually, these inflammatory cells leak back into the distal tubules and start surrounding the cast together, even with joint cell formation. So this is how you get inflammatory cells around the casts. And so one of the highly suspicious criteria is having casts which are attacked by inflammatory cells. Not only any uromodulin or any TAM-Horsfall proteins, and not any proteinaceous casts. But these casts, which are attacked by inflammatory cells, are really highly suspicious for a cast nephropathy. Another pathognomonic criteria is presence of amyloid in the cast. And be careful, this is a Congo red stain, and this is how nicely amyloid stains in Congo red stains. This is the Congo red positive stain, and you see this is a cast. This is a very nice joint cell. So we have two pathognomonic criteria in this cast. It has a joint cell reaction, and it is Congo red positive. And as we said, it's not only the Congo red positivity, it has to give you the characteristic apple green birefringence under polarized light. This is again pathognomonic for light chain cast nephropathy. Bear in mind, this does not mean that the patient has amyloidosis in his kidney. This is only the casts. The casts only have the amyloid light chains. Other than that, these patients do not have amyloidosis in the renal parenchyma, in the glomeruli, or anything else. So it's always useful to look very carefully at the Congo red of these patients. If you have a suspicious case, I'm going to show you. How many casts do we need? Do I have a certain number, a percentage of involvement within the cortex? What if I have a single casts? Do I have to have a lot of casts? Look at this case. This was a 35-year-old female who presented with renal impairment, which was unexplained, and she had this single cast. This was the only cast in her biopsy, and this cast seemed odd and was surrounded by a giant cell reaction. And I remember very well this case, it was from Tanta. And because she had only a single cost and she was young, I wrote it down that this was suspicious for lymphomas and multiple myelomas. And I remember very well that the nephrologist called me up and told me, how did you know that this patient was positive? She had a lymphoplasmacytic lymphoma. A single cost is all what you need. If it's a diagnostic pathognomonic cost, then that's it. And it's always good to raise the suspicion. However, all what the ones I've shown you are actually the classic and the florid and the advanced cases, and usually you know them by clinical wise. The problem is in the ones which you don't have the classic features. Look at this. This is a classic fractured cost, but it's a single cost among a lot of other costs. And to answer your question, Dr. Hussein, look at this. This is a pale cost in an H&E section. So you don't really know. Look at this cost. Again, this was a single cost in a biopsy, which was surrounded by a minimum cellular reaction of tubular cells. And this one, by the way, all of these patients turn to have malignancies, not only monoclonal gammopathies, although the rest of their costs were really innocuous and they absolutely showed no suspicion. As I said, looking at the Congo Reds carefully of these patients helps us. Like in this patient, you have a lot of costs, which are regular costs in tubular atrophy, but one of these costs were Congo Red positive. This was enough to make the diagnosis. Again, look at this patient. Small costs, absolutely no cellular reaction. We can all debate whether we shall consider this a fractured cost or not. But look at this cost. It's surrounded by a rim of, again, amyloidosis, Congo Red positive. So again, this makes the diagnosis. So for pathologists, look very careful at the costs in Congo Red because you might catch the diagnosis with a simple technique because they are in these innocuous cases and in patients with chronic renal disease, you can easily miss the process. Early lesions are very subtle and they have non-specific changes. As you can see here, they look very nicely in H&E, they stain PAS positive. So the staining you cannot only count on it because early lesions are not going to be weak PAS positive. Remember that early diagnosis saves kidneys, as the case I have just presented. And this makes a lot of a difference in the management of these patients in relation to their hematological disorder. These costs are going to stain by light chain restriction, either kappa, usually kappa in more than 75% of cases. As you can see here, again, this is a nice single cost with a giant cell reaction, and it's stained nicely to kappa. However, it's sometimes difficult, or usually actually, let me put it that way, the majority of the time, you cannot establish light chain restriction in the costs. In this scenario, the costs are the ones which are monoclonal. Why can't you establish it? Because you also have a lot of other non-specific costs in the biopsy. And more importantly, that by time, both the pertinent and non-pertinent light chains are absorbed within the costs. Meaning, if these are basically kappa, the very early cases, very early scenario, the costs are only kappa. But by time, these costs are also going to precipitate the lambda. And then when you come to look for monoclonality in them, you are not going to find it. Cost nephropathy, more than 75% kappa. They are usually the light chain implicated here is kappa. So it's a light microscopy diagnosis. We don't have to stain for kappa and lambda in order to come up with the diagnosis of cost nephropathy. It would be nice to have a strong kappa staining, like in this case. We always do, by the way, and I'm going to tell you why. Any case which is suspicious or which is a cost nephropathy is stained by kappa and lambda. But the staining is not to establish the diagnosis. The staining is to look for other associated lesions. So be careful of this. If kappa and lambda, or sorry, positive for both, in tissue does not exclude cause nephropathy. It excludes other things. It excludes that the patient does not have MIDD and that this amyloid is not primary and it does not have proximal tubulopathy and so on. In all the other disorders, we need to stain for kappa and lambda, but not in cause nephropathy because you can have both chains present.
Dr. Wesam, is there a difference between staining by immunohistochemical and immunofluorescence?
I was just going to say.
Yeah, okay.
We all know that fluorescence, of course, is more sensitive, but not really with kappa and lambda. It also not always gives a reproducible result. However, some labs, like in Mayo Clinic, for example, they rely completely on their kappa and lambda staining to differentiate the type of costs or to call these costs monoclonal. A more effective way with the kappa and lambda in cause nephropathy would be to use a more sophisticated technique, which is in situ hybridization, whether fluorescent or by immunohistochemistry as well. This is an available technique, by the way, and it's available in Egypt. It's just much more expensive to do. But it can be utilized for cases which are really in doubt. We can do such. So anyhow, the message is that just do not consider that a positive kappa and lambda staining within the cost is not an exclusion criteria for the diagnosis of cost nephropathy. Okay?
Okay.
The main differential diagnosis of light chain cost nephropathy surprisingly is rhabdomyolysis. Because rhabdomyolysis is going to give you, again, this pigment costs. When they are classic, you're going to get this nice beaded costs, which are again surrounded by a cellular reaction, a florid cellular reaction, which again could be inflammatory, which could be giant cells, and they can give in trichrome this nice red color. However, they can also be like this, and they can simulate light chains, and light chains can simulate the myoglobin costs. So they are always within the differential diagnosis of we can consider rhabdomyolysis or regular pigment cost-induced tubular injury. The more important differential diagnosis of it is pyelonephritis. Look at this cost. Now, this is an inflammatory, a nice inflammatory tubular cost, which does not look anything like all the costs I have been showing you. It looks completely different. This came from a patient who was 36 years old, who presented with sudden acute renal failure, and I think he was hypertensive, and there was no cause, and this was his biopsy, and it looked like an acute pyelonephritis. However, there is no reason at all for a healthy young man who's only suffering from hypertensive. And this is also valid for all our patients. Pyelonephritis is not an easy process to develop. So either these patients are stone formers, they are diabetics, you have a proper underlying cause for this pyelonephritis, or it is a cost nephropathy. And when you're going to follow these costs well in the serial sections, this is what you're going to get. Eventually, you will end up with the costs. And this patient did have a non-Hodgkin lymphoma when they looked, when the rest of his investigations were done. So please do not accept a diagnosis of a pyelonephritis in a patient when you're not supposed to have a pyelonephritis. We all know, and you know better than me, that this scenario has precipitating factors. Unless you have these precipitating factors and you have a convincing good reason that the patient has pyelonephritis, then treat this as a cost nephropathy, which was by the pathologist, or probably maybe it was not represented in the biopsy. Let's take another case. This was a 49-year-old male who was hypertensive. He was a known HCV positive. He had no treatment. This case is a bit old case. It was around the era when we just started the DAs. He presented by a recent progressive increase of serum creat from a baseline of 1.9, and the 1.9 was detected upon his routine, one of his routine visits for his blood pressure. His blood pressure was controlled, there was no complaint, and he did not have any previous reports, anything indicating whether he had any form of proteinuria. However, it progressed from a baseline of 1.9 to 4.5 milligram over 1 year. And so he presented to a different department where the nephrologist decided to biopsy him. His protein creat ratio was 900 milligram, and his urine showed only few red blood cells. There was nothing else significant in his clinical or his immunological profile was negative. C3, C4 were normal, and virology revealed their HCV. Okay, you want to see the biopsy?
Yes.
This is his biopsy. And again, this patient was not overtly chronic. He was not that acute, but he was also not that chronic. I know this is going to be difficult, so I'm going to show you. This is his glomeruli. His glomeruli didn't have anything significant. And these were some casts. They did look suspicious, that they were a bit suspicious, but what was really odd were his tubules. Look at these tubules, his proximal tubules. Let me show you on a higher power. And here we go. Do you see this? The cytoplasm of the proximal tubules had all of these lumps, huge eosinophilic structures. And look at this high power. Look at these. These are actually crystals. And here, again, a very funny looking proximal tubule. And with the PES, look, you can actually see, remember this is like microscopy. This is not EM in order that you can really see the crystals, but actually this patient, you could see the crystals. You could see that there is something here within the cytoplasm of his tubules. This is on a high power, and you can see all of these structures. And look at his kappa, extensive kappa positivity, really intense, only in proximal tubules with all of these coarse, irregular granules. And look at the distal tubules. They're really nice. They're just a bit atrophic, but there is absolutely nothing in their cytoplasm. Their cytoplasms are clean. This is their nuclei, but in comparison to the proximal tubules with all of these coarse, huge structures, which were kappa positive, lambda was completely negative, all the immunoglobulins and C3 were negative. So this is what is known as light chain proximal tubulopathy. Now, this is a relatively recent entity, and it's uncommon. It's not rare. It's uncommon disease, which is characterized by slowly progressive deterioration of renal function, plus or minus Fanconi syndrome. The basic definition is that these patients are going to have Fanconi. It's a proximal tubular dysfunction. However, not all of them. The problem with this entity is that it's a very subtle entity. It's a gradual entity. Not all patients are going to present with Fanconi, and they are clinically unexpected. You don't expect them clinically. These are usually, again, your hypertensive, your diabetic patients who have any form of other systemic disease, and you're having a slowly progressive course of rising serum creat. Their course and prognosis is variable. However, most patients at the end will develop renal failure. It will ultimately develop. But the prognosis of the patients, the overall mortality of the patient is better if they don't have an overt underlying malignancy if they don't have a multiple myeloma or a B-cell lymphoma. But if they have overt myeloma, of course, the prognosis all depends on the underlying malignancy. These cases are recurrent in transplants. However, light chain proximal tubulopathy lesions can be reversible if we manage to suppress the nephrotoxic light chain secretion, meaning that these patients are candidates for treatment. These patients should take bortezomib because then these lesions be reversible and you are improving the prognosis of the patient and the life of this kidney. Usually 50% of them meet criteria for at least a smoldering myeloma at the time of diagnosis. In 2014, this is when we started to hear about this entity, although it was first described in 2007, but it wasn't, did not have a lot of case reports. This is a typical what you get, a stable long-term renal function in a patient with copper light chain renal crystal tubulopathy. What's the mechanism here? We have just seen that in costs, the light chains interact in the distal tubules and with the uromodulin. So what about the proximal tubules? Here we don't have costs. Here we have the light chains, the free light chains inside the epithelial cells of the proximal tubules. So proximal tubules have special receptors for free light chains, which are megalin and tubulin, and they bind the free light chains where they get inside the cells by coated vesicles and then special endosomes vesicles, and they get processed inside the tubular epithelial cells by lysosomes and release their byproducts, which eventually goes back to the blood. And when it goes back to the blood, they are going to initiate an inflammatory reaction, which is going to leak again back to the kidney into the interstitium, and is going to cause fibrosis. In vitro, these changes causes also epithelial mesenchymal transformation, which will also lead to fibrosis. Once this process happens, you get activation of nuclear factor kappa beta, which is responsible for light chains. And as I said, you get transcription, a lot of chemokines and cytokines out, and you get an inflammatory reaction. So this is how the light chains interact with the proximal tubular epithelial cells. And this is how these patients with light chain proximal tubulopathy are going to end up with end stage. The pathology, as I said, it's really difficult. It's a difficult entity. If you don't have it in mind, you will easily miss it because it's subtle, it's only limited to proximal tubules, and you don't always get the nice crystals and coarse ones as we've seen in this case. Sometimes it's just your regular reabsorption droplets, which you can see in patients with heavy proteinuria. And actually they alert us because if the patient is not proteinuric, I always wonder why, or not heavily proteinuric, why does he have all of this reabsorption droplets? And it can be kappa or lambda. It does not have to be kappa. This is an entity which actually requires us to stain for light chains routinely. And this is why I'm saying that although it's reported to be less common, it's probably underdiagnosed. This is a very difficult entity to detect. We only detect the overt cases. Again, this is how it looks. This is another case with really large crystals, and you see them. This is the crystalline form. And this is how it looks on H&E. It's also, this is one, I'm sorry, I don't have a picture. I just couldn't find one. This is one which is really characteristic on trichrome stain. So we can recognize them on the spot on trichrome because the crystals inside the tubular epithelial cells stains red. So on trichrome stain, you can spot them. But this is PES, this is H&E, and this is how they look like at microscopy. Again, look at the crystals and look at them here. Here they are in light microscopy, looking exactly like the EM. As I said, they're not only limited to crystals. This was from a 73-year-old patient who was a known CLL case, and this is what he had and developed, again, acute renal impairment, and this was his biopsy. And again, this is a proximal tubulopathy, which was kappa positive, coarse. They look like microabsorption, reabsorption droplets, but they're really coarse, and you can see them here. They're suspicious, but the overt cases only are really that suspicious. Again, you can see the crystals in this case. So on light microscopy, it's going to be ATN. As I said, this entity is recurrent transplant, as you can see in this report, where they have spotted isolated tubulointerstitial light chain deposition in renal allograft. So to sum up the tubulopathic changes which can occur from light chains, so light chains can either affect proximal tubules or distal tubules. How are they going to cause tubular injury? Acute and eventually chronic injury. If it's in the proximal tubule, which we have light chain proximal tubulopathy, then we do have the binding of the free light chains, endocytosis, excessive endocytosis with excessive free light chains. Then you have a lot of cytokines, a lot of transcription factors, which will eventually lead to tubular cell apoptosis, and this is going to lead to progressive renal fibrosis, as well as I said, EMT is going to happen. If, on the other hand, this is regular cause nephropathy with the tubule, again, I'm revising, you're going to get atrophy of tubules, which are proximal to the costs, not the ones with the costs, but the tubules adjacent to the tubules in the cost. You're going to get leakage from the ultrafiltrate and the increased pressure inside the distal tubules. This leakage into the interstitium is going to cause inflammation. Any inflammation in the interstitium will eventually lead to interstitial fibrosis. As I said, the inflammatory cells crawl back into the tubules. You get giant cell formation, and these are all the causes which can precipitate, or some of the important causes which can precipitate for a light chain caused nephropathy. So it's not only distal, there are some lesions in distal tubules, other lesions in proximal tubules. The last entity, now this is really a rare entity, but just for you who's reading, because I know Dr. Correa has mentioned it in his talk last week, crystal storing histiocytosis. Now, this is basically what it means is that histiocytes are macrophages, are activated macrophages. And as you all know, macrophages have their job is phagocytosis. So they engulf any foreign material. Now, these altered or abnormal light chains are simply foreign. So sometimes they are excessively engulfed by the macrophages, and it's the macrophages which are deposited inside the tissues, not only the light chains. So what you detect are macrophages with the crystals inside of them, which again are monoclonal, they're usually copper, and sometimes these crystals also can deposit within the porocytes. So you can see them in the porocytes or in the endothelial. This is a macrophage in the capillary lumen full of cells, and they are inside. This is a very rare entity. This is from this publication. We've never seen a case. Crystal storing histiocytosis can also be in the interstitium. And again, this is EM, and you can see the macrophage with its nucleus in the interstitium, and the cytoplasm is full of light chain crystals. This is a systemic disease. It's not only renal, and these crystal storing histiocytes, they deposit everywhere: lung, spleen, liver, kidneys, and so on. And these patients have really bad prognosis. So this is to cover all the aspects of light chains in with tubular manifestations. Then what about the glomeruli? Free light chains basically interact with mesangial cells. So if whether we have amyloidogenic, back to the characteristics of the free light chains and how we develop different diseases from the same light chains. If we have amyloidogenic light chains or non-amyloidogenic light chains, they share a common receptor at, in the mesangial cells, which is the putative light chain receptor. Now, if these are amyloidogenic light chains, they get engulfed by the lysosomes, and this is going to give you fibrillar amyloid deposits within the mesangium. However, if they are non-amyloidogenic, they are engulfed by the endosomes, and this is going to give you granular deposits, not fibrillar deposits, which is the characteristic of what we call MIDD or light chain deposition disease. So you see, although they get into the mesangial cell from the same common putative receptor, it depends on the mechanism inside the cell, whether it's going to give you a fibrillar deposit or a granular deposit. This reactions also alters the phenotype of mesangial cells. However, this is only in vitro studies. If it's amyloidogenic, it alters the phenotype of the mesangial cell into macrophage phenotype, meaning that this is a more of a catabolic, it turns to be more of a catabolic cell with less smooth muscle actin and not a lot of more inflammatory cells and more mature lysosomes. On the other hand, if got engulfed by the endosomes, the mesangial cell changes into a myofibroblast phenotype with more smooth muscle actin expression and hence more fibrosis and increased extracellular matrix. At the end of the day, again, they're going to activate the same nuclear factor kappa B light chains into a transcription, and with all the inflammatory response, which is going to end at the end of the day also with increased extracellular matrix. So, AL amyloidosis. I'm not going to spend a lot of time with amyloid because we're going to discuss amyloid in detail on Friday, inshallah. However, for AL amyloid, the few points I want to point out. Number one, this is not a disease of the elderly. So although it was reported in older age groups, currently we see it as young as 30 years old. And it has varied presentation, and due to its varied presentation, it leads to delay in diagnosis. It's not always your classic nephrotic syndrome, because AL amyloid tends to be really very early and subtle, and it's one of the things which can be missed. 89% of these patients have a monoclonal gammopathy, and unlike the tubulopathic ones, in AL amyloidosis, the majority of the cases is lambda, not kappa. So usually the lambda chains are the amyloidogenic ones. However, there is, of course, up to 20% cases which are kappa, and only 20% of these patients have an underlying multiple myeloma. So that means that 80% of AL amyloid patient does not have to have an underlying malignancy. And this does not mean that the diagnosis is wrong or that these are not AL amyloid. They are still AL amyloid, although they don't have an underlying malignancy, as we're going to discuss further on. As I said, this is amyloidosis in the glomerulus. This is in the interstitium. This is classic Congo red. Again, Congo red positive, Congo red under birefringence. Again. And how did we know that this is AL amyloid? We knew by typing by immunohistochemistry, and you can see very nice lambda positive amyloid deposits in the glomerulus. And usually the kappa is always negative, and this is, as I said, these cases are more lambda than kappa. And in electron microscopy, this is how amyloid looks like, and you don't need EM for the diagnosis of amyloid. The second important point to remember is that in renal amyloidosis, you need the location of the amyloid deposits. You always need to see this, and you need to see if your report includes concurrent glomerulonephritis, which are present. This is a disease, as I said, which can be very early, which can be superimposed on other presenting pathology. It needs high clinical suspicion and high awareness on the part of the pathologist in order to be able to detect it. This is just to show you that it's not rare in our population. This is a study of ours. This is in our patients. And look at this. Yes, of course, the majority of patients are amyloid A, but we do have up to 30% of patients which are primary amyloidosis. As I said, I'm going to discuss all of this in detail again next week. This is a 43-year-old female patient who presented with acute renal failure and heavy proteinuria. She had a proteinuria 3+, a serum creat was 11. Her immune profile was pending at the time of biopsy. So here she is. She has an acute renal failure, a serum creat of 11.5, and a reported heavy proteinuria. Later on, she had normal C3 and C4. Everything was negative. ANCA-A, double-stranded DNA negative, virology negative. Her calcium was 8, potassium 6.5, uric acid 11, and they've even done a protein electrophoresis where there were no monoclonal proteins in serum or urine. So they took the biopsy. Okay, this is her biopsy. I apologize for the sections. This is a bit old case, quite an old case actually. But this was her biopsy. And now, as you can see, there was nothing in the glomeruli. She just looked chronic. You have some shrunken glomeruli with probably some mesangial proliferation, ischemic bombus, ischemic tuft, slightly thickened bombus capsule, and some atrophic tubules, and that's it. This is her PAS. Again, the tuft seemed a bit collapsed, but what was interesting that the glomerular basement membranes did not stain with PES. Do you see that? They lost the PES stain. All of these basement membranes should have been this color, like the mesangium, but surprisingly, they weren't. And this was an alerting point. Otherwise, she didn't have anything in her kidney to, apart from this, this tubular basement membranes were slightly wrinkled, slightly thickened, slightly, only slightly. Other than that, and this is another glomerulus, again, with the same problem. You feel that you cannot see the tuft because it wasn't stained, but the basement membranes were there. So we have a 43-year-old female who presented with acute renal failure and heavy proteinuria, high uric acid levels, negative UPEP and SPEP, and her biopsy showed mild mesangial proliferation and negative IF. Negative IF this was only for the immunoglobulins and the C3. We didn't do kappa and lambda at that time, not with the routine, with her routine profile. However, with her lack of staining of the PES stain, we went on and did kappa and lambda. There was something on the basement membrane preventing it from being stained with the PES stain. And so the ultimate candidate was actually light chains. And she turned to be strongly positive for kappa in her glomerular basement membranes and tubular basement membranes. And I'm going to show you her EM. And look at this. This is the glomerular basement membranes, and you have all of this black powder. We call it black powder all over the glomerular basement membranes, and this is characteristic light chain deposits. These are finely granular deposits, a very thin line. Don't confuse with dense deposits. The other ones are different, and you get thickened basement membranes. These ones are finely granular. They look powder-like, and they're very dark. And here they are. Look. And they don't look like your immune complex deposits. She had intact porocytes, and she was a light chain, and she also had the light chains in her tubular basement membranes, as you can see here. So her diagnosis was consistent with light chain deposition disease. Bone marrow aspiration showed 35% plasma cells. Although this is a very old case, I keep it because it was really a difficult case, and she was only 40 something. We did not do routine kappa and lambda. So monoclonal immunoglobulin deposition disease, or what we call MIDD, you could have either light chain, light and heavy chain, or heavy chains deposits, but they are all monoclonal. What is this disease? This disease that you get amorphous deposits. Amorphous means structureless deposits, and these deposits lack Congo red staining. This is very important, and lack amyloid P component as well. They are not amyloid at all, and they will stain with antibodies for the class of light or heavy chain. Again, this is a disease which is majority kappa. So more than 70% of cases are kappa. Their kappa is usually abnormal. That's to say it's altered, they're broken. So you have partial light chains or excessively large light chains. And maybe this is why, one of the reasons why they are not so common, because we cannot easily detect them. Light chain disease causes changes in the whole kidney, glomeruli, tubules, and blood vessels. In the glomeruli, you get variable minimal lesions, as you can see here. A pretty innocent glomerulus, really very difficult to doubt. But to typically nodular, classic, of course, this falls into the differential diagnosis of diabetes. You get thickened tubular basement membranes, again, falls in differential diagnosis of diabetes. And when we come to diabetes, I'm going to show you they are identical. It's really very difficult to differentiate between these two diseases. And if you don't do kappa and lambda, of course. And the vessels are usually thickened with smooth muscle basement membranes. But lovely, and you can see here very nicely stained tubular basement membranes for the kappa. And lambda does not give you this same technique. This is by immuno, and this is by fluorescence. And this is how light chains deposits around the tubules or on glomerular basement membranes. Again, even the nodular sclerosis could vary from just early nodules. It can give you all the whole spectrum, with just mild mesangial matrix expansion up to full nodular pattern. Again, this is a high power, just to show you this is kappa, a higher power with immunohistochemistry, and again, very nice kappa deposited along tubular basement membranes. EM, again, to show you more clearly than the case how light chains looks like, and this is what we call this black powder, this finely granular, very granular deposits along glomerular basement membranes and tubular basement membranes. This is the blood vessels of these patients, and they are a telltale sign. If you're a bit lost, you can look at the blood vessels, because light chains deposit within the arteries and give them a bit of a funny shape. But you can see this can easily pass as your regular chronic kidney if you don't have this diagnosis in doubt, or if your patient is young and you're not considering to stain and lambda. Monoclonal deposits can also be heavy chains. Now, this is extremely rare. I've never seen a case. I think there are only very few cases reported in the literature. And it is rare. It's a rare monoclonal immunoglobulin-related disorder. And we don't even know its fully explored pathogenesis. And what happens is that it's characterized by production and systemic deposition of structurally abnormal immunoglobulin heavy chains, while no light chains. As I said in the introduction, we're discussing it, heavy chains. This is one of the diseases where you can see only heavy chains, and the other one is amyloid. A light chain amyloidosis or monoclonal amyloid, you can be heavy chain as well. These are the only two scenarios that you're going to see an only heavy chain deposition disease. How does it look like? Exactly like deposition disease. So the trick here is that when you have these cases, that these cases are going to stain for one immunoglobulin, whether IgG, commonly IgG, of course, much less commonly IgM, and very rarely IgA, with no kappa and lambda, and no C3. So you have an isolated immunoglobulin, which usually doesn't make sense. And you have this nodular sclerosis pattern, and by electron microscopy, these deposits are not immune complex. They are finely granular deposits, but they are more dense than the light chain deposit. They are bigger, basically. And sometimes you can get complement deposits. This was a case with IgG heavy chain deposition disease, and the problem here was in the gamma heavy chain. And as you can see, this is the IgG bright everywhere, in the tubules, in the glomeruli, in the mesangium, along the glomerular basement membranes. Everything was IgG, but no kappa or lambda. So this is definitely an abnormal IgG. Let me remind you again, so you don't get lost. This is our immunoglobulin, and we've agreed that here we have the light chains, and here we have the constant regions, and here we have the variable regions, and we have the light chains here. And in heavy chain disease, you get the variable size deletion in heavy chain disease in this segment, and they also lose the light chain binding site, so they have no light chains. And usually the mutations in CH1, which is one of the constant factors here in this segment. However, the complement binding sites are intact, so you can still see sometimes C3 in this disease. Very difficult to diagnose if you have IgG and also C3. If you don't stain for kappa and lambda, then you are missing it. And as I said, this case, which was published in 1998 in NDT, showed constant deletion of the gamma heavy chain CH1 domain. So this is basically a chain disease. Okay, this is another case. Okay, this is a 42-year-old female, also presenting with unexplained rise of serum creat. Her serum creat was 6. She had absolutely no history of medical disease. She presented with minimum proteinuria, and urine albumin creat ratio was 430 milligram, and her examination revealed no abnormality, and nobody knew why was her serum creat. Her serum creat was 6. She was mildly anemic, I remember. I mean, the first question did she look chronic? And the answer was no. Everything was marginal. Oral immuno was negative. Again, normal C3 and C4. And these type of case scenarios, you really have to consider light chains, irrespective of the patient's age. Look at her biopsy. And her biopsy looked normal, more or less. Again, very nice glomeruli. Now, there is no mesangial proliferation, no loss of staining or anything. Everything is intact. Her tubules looked a bit atrophic. They did have some thickened tubular basement membranes. Look at other areas. And here we go. Quite prominent tubular basement membranes for a patient who has no disease, no medical disease to explain this. And then you get this amorphous, this is not a cost. This is typical amorphous pink deposits, which you can see sometimes these islands in light chain disease patients. So you get this deposits, this amorphous irregular deposits within, usually in the medulla or at the corticomedullary junction. And look at tubular basement membranes. Look how wrinkled they are and thickened. Give a lovely staining for kappa. And again, no lambda. And these are the inflammatory cells in the interstitium. She had some tubulointerstitial inflammation, and they were also, of course, the inflammatory cells will stain for kappa. Again, this is again her kappa staining. You see very nice kappa staining along these wrinkled tubular basement membranes. And compare this to the proximal tubulopathy. The cytoplasm here is negative. There is no brown staining here. Although in proximal tubulopathy, it was these areas which were positive and the basement membranes were negative. And we had EM for this patient who was slightly autolyzed, but we can still see this is a proximal tubule, and you can see the deposits. Very nice light chain deposits. Of course, not nice for the patient, but you can see finally granular, again, this black powder light chain deposits across the tubular basement membranes. So the last pathologic spectrum which we can include under light chain deposition disease is that you can have a light chain mediated acute tubulointerstitial nephritis without glomerular light chain deposits. So your classic MIDD is going to involve glomerular and tubular, and it requires for its diagnosis that you have light chain deposits on glomerular basement membranes like our first patient, like the first patients who did not have staining and had all the light chains on glomerular basement membranes, plus or minus tubular basement membranes. However, we have the other entity, like this last patient, where the light chains could be only on tubular basement membranes and would induce some form of acute tubulointerstitial nephritis, and you have absolutely nothing in the glomeruli. Again, thinking out of the dogma. Again, think out of the box. Again, think about your patients which are going to present with renal impairment and get an unexplained diagnosis of an interstitial nephritis when there is nothing to explain why these patients have interstitial nephritis. So, to sum up, monoclonal immunoglobulin disease could be pure only, like in this study by Vivat Dagazzi, a very old study, but things really did not change. The point of this is that in monoclonal immunoglobulin deposition disease, you can also get myeloma-caused nephropathy with it. These patients could or could not have an underlying malignancies, the one with pure MIDD, while if you have both, you definitely have an underlying malignancy. And in all of them, in pure MIDD, you're going to get, it can be light chain, it can be light and heavy chain, and it can be heavy chain. Of course, the commonest, almost equal the other two entities, is that you're going to have it light chain. Amyloidosis is also common with in these patients, and you have to look for it quite carefully. However, if you have a caused nephropathy, then you're only dealing with light chains. There are no options here because these patients will turn out to be myeloma or lymphoma patients, and there is no place for a heavy chain disease here. I would like to stop here and we see if we have any questions, if any, before we proceed. If there is anything of what was said which was not clear, does anybody have any question in the entities we've discussed? I've discussed mainly the common entities, the caused nephropathy, the MIDD, the myeloma, and less common entity, which is light chain proximal tubulopathy. So before we proceed for the pure related monoclonal gammopathy diseases, and we move to the glomerular diseases associated with monoclonal gammopathies, I would like to see if we're all clear, if anybody has any question.
Professor Darat Bilal and then Professor Adam.
Much for the very rich talk. أنا عايزة أسأل في الفراكتشرد casts. أنت قلتي كفاية واحدة عشان نشخص. مش في other causes of appearance of fracture casts which are not pathognomonic of gammopathy.
لا ثانية واحدة.
drugs بتعمل كده؟ يعني أنت بتقولي واحدة بس. One cast is enough to diagnose.
Okay, a fractured cast is not pathognomonic for light chains. A fractured cast is not pathognomonic.
Not to diagnose.
No, a fractured cast is not pathognomonic. A pathognomonic if the cast has a giant cell reaction, or if it's Congo red, positive, then this is enough for diagnosis. One cast is enough. But if I have one fractured cast, this should raise my suspicion, but it's not pathognomonic. So this is number one. Number two, no drugs causes fractured casts, and there are no other reason for what we call fractured cast, which are sharp and they seem fractured, because simply casts in these casts are fractured because light chains are tough, so they are fractured along their way within the distal convoluted tubules because of the convolutions. Have this.
You need to confirm by immunohistochemistry. يعني ممكن light microscopy يدي fractured cast which is not really a fractured cast.
Well, as I said, immunohistochemistry, yes, or I will do immunohistochemistry of course, but it might help and it might not help.
يعني الدكتوره دولت بس يعني الدكتوره دولت اظن هي بتعني هل ممكن الفراشر كاست تبقى تكنيكال rather than pathology؟ يعني ممكن تبقى خلل في اوكي.
But bear in mind that it's fractured cast, that it just does not look like a missing cast. But the whole idea is the identification of what we call a fractured cast. But once you have a fractured cast, you have to look for para-proteins. They might be positive, they might be negative. They could be just excessive light chains which were filtered through the kidney and it produced some of these casts. But yes, but this is not a technical thing, but it's still light chains and they are still suspicious. So there is a difference. If I have a single pathognomonic cast, yes, this is enough for a diagnosis. If I have casts which look suspicious and they don't have the pathognomonic features, we just write them suspicious for we just alert you to go ahead and look for cast nephropathy.
And how can you confirm بقى suspicious دول؟
لا, these are by serology and bone marrow. I don't have confirmation.
Okay.
Professor Adam, تفضل.
Yes, please. Actually, correct me if I misunderstood this. You showed us two cases. One of them has got PS stain in the basement membrane lost in some areas, and this is due to kappa deposition light chain disease. And the following case is quite the other side of the coin, because the basement membrane with PS stain is so thick, and it is still due to kappa light chain.
No,
so
the other one did not have glomerular basement membrane deposits. The last one was isolated tubular deposits.
In the basement membrane of the tubules?
Yes, the basement membrane of the glomeruli was fine.
So the same molecule causing, preventing the PS stain from the glomerular membrane, and
yes,
the other
PS positive in the tubular basement membrane. Yes. I don't know why.
Same molecule.
I asked this question before. I don't know. I don't know why does it lose the stain in the PES, in the glomerular basement membranes, and doesn't lose it in the tubules.
All right. Can I ask you, do you have any differential?
Why? Please tell me. Sure.
Do we have any differential diagnosis of lost staining of the PS stain in the glomerular basement membrane apart from light chain disease? Am I clear?
Yes, you're clear. Yes, you can have it if you have segmental amyloid deposits. You're also going to lose the stain, or you're going to
segmental amyloid AA or AL?
Whatever the type of amyloidosis.
Dr. Wesam, does it will be like in the silver stain?
Yes, it doesn't stain in the silver stain as well. It gets lost in the silver
even
stain.
in dense deposit disease, the same. If silver stain is lost, it's lost because of deposits. I think so.
And it's still, but in dense deposit, it's also lost in the tubules. But that doesn't happen with the light chains.
Okay.
I think maybe, this is just what I can think of. in that in the tubular basement membranes, they are actually outside the membrane. They are not really integrated, as you can see it in the EM. But in the glomerular basement membrane, they are integrated within the glomerular basement membrane structure. So maybe that's why in this entity, they lose the stain. But that's the only logical explanation I could come with. I don't really know.
Can you look at the chat, Dr. Wesam, and just Dr. Hani Mansour from Saudi, why there is poor correlation between blood work, bone marrow, and biopsy? Do you have?
Yes, of course I do. Because in blood work usually is not consistent. That's number one. Number two, you do only a protein electrophoresis, and this is, in some reports, it's 85% specific, but I think it's much less specific than this. You always need to have an immunofixation with your serum protein electrophoresis. You need only to do it in serum because this is highly sensitive, not in urine. So don't come and say that I have a urine PEP with immunofixation which turned negative, because it is going to be negative. And so that's one thing. And sometimes you even get the immunofixation negative, but you get an altered ratio. So you need to do serum-free light chains. And then you need to do bone marrow. Unfortunately, yes, there is, they are so varied, and they're different. They're also, clinical pathologists are giving us a very hard time, and not everyone interprets them, these diseases properly. And also an important point, which is not included in the talk, but since we're talking about the lab work, a hypogammaglobulinemia does not exclude light chains. Actually, it's a sign of it, because light chains causes immunodepression. So we had also a number of cases where I had in the report that this patients have a hypogammaglobulinemia, and this by default excludes that this patient is going to be a light chain disease or a myeloma or a lymphoma, when actually they are, because light chains have the capacity to suppress the gamma globulins. So no, they are not straightforward. They are not easy. Just don't take a look at the clinical pathology. Look at the curve yourself. Repeat it. If the patient is highly suspicious clinically or by biopsy, go the whole way. We have diagnosed patients with only bone marrow. And for this reason, for example, here, being cost effective, if the biopsy is really highly suggestive, we recommend that the patient just go do bone marrow to save a lot of other serology tests which might not be conclusive.
And I think it's better to go and to remind what was mentioned by Professor Qurai'a regarding the pattern of light chain plus protein electrophoresis plus immune fixation, and not only to be rigid to immune electrophoresis, because
yes. Protein electrophoresis is not specific basically, so a negative SPEP doesn't say anything. For us, this is useless.
Okay, let us have this question from the chat as well. Can cast nephropathy present in a diabetic patient and misdiagnosed as pyelonephritis? I want you just to concentrate on this point, because whenever we find infected cast, we say pyelonephritis.
Yes.
But it's not necessarily to find cast nephropathy. And I think this is a smart eye of the pathologist to just look thoroughly to the specimen.
And you need
but
a lot of...
The majority is the pyelonephritis, yes. If we have infected cast, it's pyelonephritis in the majority of cases.
Yes, if you have an infected cast. Yes. And when we come to tubulointerstitial diseases, I'm going to hopefully convince you that it's not that easy to diagnose pyelonephritis.
Okay.
And that pyelonephritis needs, you need to really have very strict criteria. And this is a waste basket where pathologists use. So the important point for us is that even in diabetics, yes, cast nephropathy can give you the same, but check the patient. We're not losing anything. I'm not telling you go and do an invasive procedure, since we have a good background for the pyelonephritis, but at least do an IF SPEP for these patients. And you would be, believe me, you would be surprised. There is another question, difference between MIDD and cause nephropathy. I suppose they are the same spectrum. They are all the same spectrum. We're still talking about the same spectrum of the disease. It just depends whether the light chains, where the light chains go, what's their mechanism, and where they lie in the kidney. So this comes with the different varied presentations, but they are different, of course. MIDD is something, and cause nephropathy is another thing. And for a clinician, the main difference is that cause nephropathy is reversible, the recurrence is late. This is where you can save the kidney. MIDD carries a very poor prognosis, whether they have underlying malignancy or not, 100% recurrence rate in transplants, and these patients have a very poor prognosis. So yes, they differ. We're still speaking about the same spectrum of diseases, but each presentation of these diseases differs in relation to the prognosis of your patient and his clinical presentation.
Okay.
AL amyloid is almost secondary to blood dyscrasias.
I think amyloid will be discussed in the next session.
Amyloid is going to be discussed in the same.
From سلطنة عمان vancomycin طارق زيان دكتور طارق زيان vancomycin associated cause nephropathy.
Vancomycin associated cause nephropathy. Does it fracture the light microscopy? Also reactions around the cost. Okay, what causes a cause nephropathy like lesion? Of course, the most known, وبرضه to answer دكتورة دور, that is rapamycin. But how many patients do we are on rapamycin to put it in a differential diagnosis of a native kidney in a patient presenting with acute renal failure? Some cases of vancomycin, yes, have been reported. Again, this is a clinical differential diagnosis.
The only way to say vancomycin cast is to prove it is vancomycin, and there is specific staining for the vancomycin, and electron microscopy, and we can find the cast was vancomycin. It's not vancomycin. Yes. So I think it is enough.
By the way, but light chain cause nephropathy are much more common than rapamycin, than drug-induced cause nephropathy. Okay, so let's continue. Glomerular disease associated with monoclonal gammopathies. Now, this entity was thought to be limited only to lesions which involve light chain deposits, which what we basically discussed now, which is a monoclonal immunodeposition disease and AL amyloidosis. However, recently it includes other forms of glomerulonephritis. And the injury here could be, or the process, the mechanism, could be mediated through cytokines, like when you get a minimal change disease, for example, or through dysregulation of the alternative pathway of complement. So you end up with a C3 glomerulopathy, or with a thrombotic microangiopathy. Or you can have an immune complex mediated GN with light chain restriction. So we're moving here into another section of the spectrum of these diseases. The first section, we've discussed the direct mechanisms. What's going to happen to the kidney when these light chains directly deposit into the kidney in its various compartments. However, these light chains can also cause other problems through indirect injury and can present with glomerulonephritis. GN with monoclonal deposits includes almost every glomerulonephritis we know, apart from segmental glomerulosclerosis. Glomerular disease type could be matrix or abnormal protein accumulation, as we've discussed. So you can have AL amyloid, you can have MIDD, you can have an entity known as myeloproliferative neoplasm. This is out of the spectrum of this talk. Maybe I'll show you a case when we are done if you want to see interesting cases, but this is very rare. immunotactoid glomerulopathy, Waldenstrom macroglobulinemia. This is where you have some forms of abnormal protein or abnormal matrix accumulation. Then you have the proliferative ones. Here it's not deposits. In this scenario, you have a proliferative glomerulonephritis, hypercellular glomeruli. So you have proliferative glomerulonephritis with monoclonal IgG deposits. You have cryoglobinemic GN type 1, and you have intraglomerular intracapillary lymphoma or leukemia. Again, this is in recent a form of lymphoma, which is known as intravascular lymphoma or leukemia. And this is where the malignancy is restricted to the blood vessels. And since glomeruli are capillary loops, so you can see, again, a very rare entity. But it's nice. It's easy to catch on a biopsy for a pathologist. It's not difficult because you get all the malignant cells within the capillaries. Or you can have a podocytopathy. You all know this. You all know better than me that minimal change can be simply secondary to underlying hematological malignancy. This is for all the hematopoietic neoplasms, which makes me stress, if I did not stress earlier, that when we come to discuss underlying malignancies, we are not only talking about multiple myeloma and B-cell lymphomas, all type of B-cell lymphomas. Look here, you have multiple myelomas. Here is a myeloproliferative, even myeloproliferative neoplasm. Here, low-grade B-cell lymphomas, particularly CLL and SLL, also cause small cell lymphoma. Waldenstrom macroglobulinemia, which is usually lymphoplasmacytic lymphoma. Here again, these patients, uncommon that you find in proliferative GN, uncommon to find malignancy. Cryoglobinemic GN type 1 is almost exclusively lymphomas. You don't see myelomas. Here you have large B-cell lymphomas and leukemias, and here you have Hodgkin's lymphoma. So actually lymphomas dominate the list more than multiple myelomas. So remember this, and remember that we don't diagnose lymphoma by bone marrow biopsies. It's only a myeloma. So a bone marrow biopsy is going to tell you that the patient is not myeloma, but it's not going to tell you that the patient is lymphoma, because if you have a lymphoma, it does not have to infiltrate the bone marrow. This is only staging. I'm also going to details about fibrillary GN because we're going to cover it in the second session with organized deposits and amyloidosis. But a word on fibrillary glomerulonephritis. Fibrillary glomerulonephritis could be monoclonal, so could only copper deposits in it or lambda together with the IgG and C3. Same for the percentage of monoclonality in fibrillary GN is only 25%. That means that in 75%, fibrillary GN is not a monoclonal glomerulonephritis, just glomerulonephritis. While in immunotactoid glomerulonephritis, this is a different story. This glomerulonephritis is monoclonal in 75% of the cases, and mostly copper. So immunotactoid raises a very high suspicion of monoclonality and underlying malignancy, and as I said, commonly lymphomas in these patients. And immunotactoid is a disease of the elderly. Honestly, it does not come in young people. Next is Waldenstrom macroglobulinemia, hyperviscosity IgM disease, monoclonal IgM and renal disease. All what we've been discussing before were the kappa and lambda chains, usually originating from an IgG. Now this is a pure IgM disease, and all of this list is going to cause Waldenstrom macroglobulinemia. CLL, B-cell, any type of B-cell lymphoma, not only lymphoplasmacytic. Multiple myeloma can also cause Waldenstrom macroglobulinemia, and a benign monoclonal gammopathy, so with no underlying malignancy. Clinically, these patients present with a variable clinical presentation. They can come with nephrotic syndrome, they can come with acute renal failure if they have vasculitis, hyperviscosity syndrome, they will have IgM kappa and HCV. Usually they are HCV positive. It's typically your HCV cryoglobulin, and it's going to be an IgM kappa. If it's an HCV, the type 1 is going to only be kappa positive. So it's a cryoglobulinemia. It doesn't make any difference from the regular MPGN cryo. You get a proliferative glomerulonephritis with these nice cryos inside the capillary basement membranes. You got a typical membranoproliferative GN, as we've discussed before, with numerous histiocytes and macrophages and inflammation. So this is again a disease where you have to raise suspicion. When you usually say patients are definitely, in a country like ours, I look for HCV 10 times before I consider that this could be just a type 1 cryoglobulinemia, which are not common. What about the proliferative glomerulonephritis? Now, as I said, the monoclonal immunoglobulin in the setting of a B cell or plasma cell disorder can cause a proliferative glomerulonephritis via 2 mechanisms. The first mechanism, we call it the direct mechanism, where glomerular deposition of the monoclonal immunoglobulin with activation of the classical pathway of complement results in an immunoglobulin, immune complex mediated positive C3 glomerulonephritis. So you get a full-blown immune complex mediated glomerulonephritis. What's monoclonal in it? That I have only a single light chain, as we said. So we have proliferative glomerulonephritis with monoclonal IgG deposits. Sorry, this is a typo. It's only kappa. There's no lambda here. So you have light chain restriction, only kappa, strong staining for C3, they're usually strong stained C3, and they are also IgG with an IgG3 subtype. So this is an entity, again, which was first described in 2004. This is a rare entity, but an entity which we should consider in a patient who comes out of the blues, especially if he's over 50 years old, and then you get a diagnosis of a proliferative glomerulonephritis, or a diagnosis of an infection-related glomerulonephritis, because it can be easily diagnosed as an infection-related glomerulonephritis. You need to ask for kappa and lambda and see whether these patients have monoclonal deposits or not, before, if you cannot locate an underlying infection, and if the patient does not precipitate infection, if he's not an immunocompromised patient. This also comes middle-aged patients, 30 and 40, and this one is recurrent post-transplant. So it needs to be diagnosed. The good news is that these patients do not have an underlying malignancy. They only have a monoclonal deposits in their kidney, but the majority does not have an underlying malignancy. The other mechanism is the indirect mechanism, where you get glomerular deposits of complement factors of the alternative and terminal pathway. Why does this happen? Because you get inhibition of the alternative complement pathway by the light chains. Let me show you. On one side, here is your monoclonal immunoglobulin up there. And then on one side, you have a direct mechanism. This is your light chains. And then these light chains will activate the classical pathway, and then they're going to deposit here on the glomerular basement membrane, and then you will get neutrophils and monocytes, you get your full-blown proliferative glomerulonephritis, and you get damaged endothelium, and you get your immune complex deposits. While in the indirect mechanism, what happens is that the light chains actually activates the alternative pathway and causes alteration of the alternative pathway. And I think we've discussed extensively what happens if we have a dysregulation of the alternative pathway, because they do bind, the complement bind to the light chains in the serum. And then you have the complement here. Again, in this scenario, it's only the C3 which is going to deposit, but no light chains, do you see? Here we have the light chains. Here we don't. So again, because I know this area is confusing. If I have a monoclonal gammopathy, meaning we have abnormal light chains in the serum. Light chains can cause proliferative glomerulonephritis through two mechanisms. The first mechanism is that the light chain themselves activates the complement pathways and causes immune complex mediated, and all of them, and binds to the immune complex mediated. The light chains will deposit on the glomerular basement membranes together with the C3 and the IgG. So you are going to, when you come to look for them, you're going to find them all. You're going to find the IgG, you're going to find the C3, and you're going to find the kappa. While in the other scenario, the light chains are not deposited. The light chains cause alteration of the complement pathway in the serum, and what gets deposited is the excessive C3 and no light chains. Here they are still in the blood. They did not deposit in the tissue. And you get again a proliferative glomerulonephritis, which is a C3 glomerulonephritis. So this is the difference between the direct mechanism and the indirect mechanism. Let's take an example. This is a patient who's a 73-year-old man with nephrotic syndrome, hypertension, and worsening kidney function. And look at his BS chain. It looked like an MPGN, but it's more proliferative. And the basement membrane duplication was really rare. So it's a proliferative glomerulonephritis. His immune showed IgG, 9C3, and kappa, and no lambda. His EM showed subendothelial deposits. On further evaluation, his serum immunofixation studies did not reveal monoclonal bands, as I was just asked. So this patient, even his immunofixation SPEP did not show any monoclonal bands. However, when serum free light chains were measured, they were, kappa was really elevated and the ratio was 2.1. So this is a proliferative glomerulonephritis with monoclonal deposits. And these patients, yes, they do get to end-stage disease, end-stage renal disease, but they don't have an underlying malignancy. Now, this is again another proliferative glomerulonephritis. Looks like a nice proliferative glomerulonephritis. Is not really different from the first case. Now, this was a woman who's 53-year-old with nephrotic syndrome and hypertension. She already had serum immunofixation studies, and they revealed IgG kappa. Her bone marrow studies revealed slightly increased numbers of plasma cells, only 5%, with kappa light chain restriction, and she had no cryoglobulins. Her biopsy showed only C3, and she had these extensive subendothelial deposits consistent with the C3 glomerulonephritis. She had no kappa, no lambda, no IgG in her biopsy. Bottom line, not to confuse you, if we have an unexplained C3 glomerulonephritis in an elderly patient, or if this C3 glomerulonephritis was interpreted as glomerulonephritis, you need to look for monoclonal deposits in the serum and investigate well whether the patient has any form of malignancy. This is the bottom line. The last entity I'm going to discuss is thrombotic microangiopathy. Now, the relationship of thrombotic microangiopathy to underlying malignancies is not new. And we've always known that an underlying malignancy can cause a thrombotic microangiopathy, especially solid organ tumors, especially mucin secreting tumors, out of the mechanism of hyperviscosity, and if the patients of the tumor emboli circulating in the blood, which causes endothelial damage. However, there was a recent recent data again from Mayo Clinic, which they have segregated their the association of TMA with monoclonal gammopathies, and they have concluded that it's far more frequent than previously appreciated. So they have studied 146 patients with TMA and have detected monoclonal immunoglobulin in 20 of them, so around 14%. However, when they have looked in cases only 50 years and older, the prevalence of monoclonal gammopathy was raised from 14% to 21%. They said that this is approximately 5-fold higher than the expected rate in this population. However, we also expect that the older you get, the more prone you would be to have some form of disordered proliferation. Hypothesis, as I said, is direct endothelial injury by the monoclonal protein, or an indirect, again, via cytokines induced by the light chains. Okay, so TMA is not the last. We still have membranous. This is also rare, but membranous glomerulopathy can present with light chain restricted deposits. This is a report only by Christopher Larson from Arcana Laboratories, and Chris have reported 28 cases of membranous glomerulonephritis with copper restriction, and their mean age was 62 years old. They were all nephrotic and so on. However, the important point was that he has described that phospholipase was positive in 7 of 27 of these cases, and this was a point we've discussed when we were discussing membranous, and that even if you have phospholipase positivity in elderly patients above 60-year-old who present with membranous, you still need to look for underlying malignancy, especially hematologic. Patients could have different features, like they could have some mesangial proliferation, and they could have crescents, and we've also mentioned this in membranous. So the presence of proliferation and crescents, and if they are phospholipase negative, and if they are elderly, this goes that this membranous has a good chance that it's going to be monoclonal. This study was not reproduced by anybody else. We'll come to the last section of this talk, where I'm going to more or less again sum up what we've discussed. Monoclonal gammopathy of renal significance. Okay, now I have been discussing all the talk and saying, and this also would answer the question about the amyloidosis, the primary amyloid, that monoclonal gammopathies can present with so many various presentation in the kidney, but with 20 to 50% of patients having only underlying malignancy. That means that I can have a patient with a monoclonal gammopathy and evidence in the kidney that the kidney lesion is related to this monoclonal gammopathy or to this light chain. Let me make it simple. But this patient does not have an underlying malignancy. Then what is this? So these cases, which were attributed to a clonal plasma cell disorder, and they lie in a gray zone. They are less myeloma-like and more monoclonal gammopathy of undetermined significance-like. When we were younger, what we knew is that we have patients with what we called MGRS, that patients could have monoclonal gammopathy and they can have abnormal light chains in their serum with no significance, and that these patients are for follow-up. And then we started to recognize that we can have light chain related diseases in the kidney with patients who has MGRS, but they don't have malignancy. They don't have myeloma, they don't have lymphoma. So Trent started to come up with, is this an AL amyloid with MGRS? is this monoclonal immunoglobulin deposition disease with MGRS? Is this a GN with MGRS? But the point is, there is significance to this monoclonal gammopathy. I cannot say that this is of undetermined significance. This is not MGRS. And its significance is not undetermined because its significance in the kidney. These light chains I detected in the blood have caused organ damage. I have detected them in the kidney. So this is not of undetermined significance. And because of this, the term monoclonal gammopathy of renal significance have been introduced. So this term, MGRS, or monoclonal gammopathy of renal significance, regroups. It's just a regrouping of all renal disorders which are caused by a monoclonal immunoglobulin secreted by a non-malignant B-cell clone. يعني إيه؟ يعني all the diseases of the patients where they have light chain diseases in their serum, abnormal light chain in their serum, and they have a renal problem related to the light chain, and they don't have malignancy. What we call them? We call them MGRS. So this is why primary or AL amyloidosis, only 20% of patients have an underlying malignancy. The rest, 80%, are MGRS. And this is the commonest and the most known example of MGRS. So by definition, patients with MGRS for the zillion times do not meet the criteria for overt multiple myeloma or B-cell proliferation. And they have a hematological disorder which is consistent with either a monoclonal gammopathy of undetermined significance, smoldering asymptomatic multiple myeloma, a low-grade lymphoplasmacytic lymphoma with Waldenstrom macroglobulinemia. So they could have a low-grade lymphoplasmacytic lymphoma or a low-grade Waldenstrom macroglobulinemia, or what we call a smoldering or asymptomatic multiple myeloma. But also and monoclonal gammopathy of undetermined significance. What are the B-cell and plasma cell proliferative disorders which can cause MGRS? We have NGUS, any clone, doesn't make a difference. In bone marrow, you have less than 10% plasma cells, so this is NGUS. Immunoglobulin, any immunoglobulin, IgM, IgG, IgA, the M spike is less than 30. And organ damage and involvement, none. So this is monoclonal gammopathy of undetermined significance. Smoldering multiple myeloma, plasma cell, 10 to 60% in the bone marrow, any and more than or equal 30, and no organ damage. You still call it a smoldering multiple myeloma, even if the bone marrow is infiltrated up to 60%. Organ damage is a very important point. Multiple myeloma, if you have any organ damage or any one of the slim crab criteria and only more than or equal of 10% plasma cells in bone marrow, this is a full-blown multiple myeloma. Then we have again smoldering Waldenstrom macroglobulinemia, monoclonal B-cell lymphocytosis, CLL, and all the types without getting into too much hematology details, not to bore you. The bottom line is this has to be correlated with what we have in the patient. And as I said, you just don't look and see the patient does not have an M band. No, it doesn't work that way. You need to see the M spike, you need to look at everything. And in smoldering multiple myeloma or full-blown multiple myeloma, and also in smoldering Waldenstrom macroglobulinemia and Waldenstrom macroglobulinemia, it's enough to have either bone marrow involvement or an M spike above this threshold is sufficient for the diagnosis. I hope I'm clear. because this CRAB criteria is present in only 30% of patients with myeloma. So can I diagnose myeloma because I had suspicious biopsy and then the bone marrow showed more than 10% plasma cell infiltrate? Yes, you can. And you see either bone marrow involvement or a spike above these thresholds. So you need to compare both because this also doesn't happen. So if I have an M spike, which equals 30, which is borderline, and I have no slim CRAB criteria for myeloma, but I have a suggestive biopsy and I have a bone marrow of more than 10% infiltrate, then this is multiple myeloma. It's not even smoldering. This is multiple, full-blown multiple myeloma. Or the other way around, if I have less than 10% bone marrow involvement, but I have an M spike, which is really high, and I have any of the GRAB criteria, which includes end organ damage, which is the kidney, then this would be sufficient for diagnosis. So the diagnosis of MGRS-related disease is established by kidney biopsy and, of course, immunofluorescence or immunohistochemistry studies to identify the monotypic immunoglobulin deposits. Bearing in mind that these deposits are minimal in patients with either C3 glomerulonephritis or thrombotic microangiopathy. I'm not going to get any copper or lambda staining in the biopsy. MGRS, in spite of that the patient does not have an underlying malignancy, is associated with high morbidity due to the severity of renal and sometimes systemic lesions induced by the monoclonal immunoglobulin, and these patients are treated not with the same regimen like a full-blown multiple myeloma, but all of them are candidates for Velcade or bortezomib. In 2019, just 6 months ago, this paper was published, and the updated definition of MGRS, according to a consensus meeting, there is nothing changed. It's the same. This is what we mean by MGRS. It would apply specifically to any B cell or plasma cell clone with both of the following characteristics, because it's a monoclonal gammopathy of renal significance. So I need to have one or more, because as I said, they could be combined, kidney lesions that are related to the produced monoclonal immunoglobulin, the underlying lymphoproliferative problem or the underlying hematological problem does not meet the criteria for a full-blown malignancy. What if it meets the criteria for full-blown malignancy? There is no problem. I still have to look carefully if the patient has a full-blown malignancy. If it meets the criteria of a full-blown malignancy, then it's caused by the full-blown malignancy. It's just we're not going to call it MGRS. We're going to call it myeloma kidney, as you've always called it. Or a B-cell lymphoma light chain disease. This, Ahmed Correa have shown you this, and I'm showing it to you again. And I think this diagram mainly encompasses all what I've discussed today, except I hope that you notice that it's absent no cost nephropathy, because you are not going to get a cost nephropathy in an MGRS. Actually, our regular commonest lesion light chain cost nephropathy is always related, unfortunately, to underlying multiple myelomas. These patients usually have an underlying malignancy. However, anything else of all the entities we've covered today could be just an MGRS, just a light chain disease problem, or these patients could have an underlying malignancy with different percentages. Less percentages with amyloidosis, higher percentages with light chain proximal tubulopathy and MIDD, less percentage with C3 glomerular monoclonal gammopathy. So in these patients, up to 50% have an underlying malignancy. In these groups, up to 20, here up to 70% have underlying malignancy. Here, up to 20% only. Again, here, 20%. Type 1 and type 2. This one is high as well. This can climb up to 50%. This, as I said, are rare, and usually patients can have an underlying malignancy and so on. This one, almost 5%, the PGN-MID, very rare to find an underlying malignancy. So this is a pure ESNT-CME and C3 glomerulonephritis. So MGRS associated disease, what we've discussed today, monoclonal immunoglobulin, either caused by monoclonal direct mechanism, monoclonal deposits directly, giving you amyloidosis, immunotactoid, fibrillary, if they are fibrillar. If they are microtubular, they're going to give you immunotactoid cryoglobulins. If they are inclusions or crystalline deposits, they're going to give you light chain proximal tubulopathy or crystal storing histiocytosis. If they are non-organized or finely granular deposits, they're going to give you a monoclonal immunoglobulin deposition disease, MIDD, or a proliferative glomerulonephritis with monoclonal immunodeposits. And if I cannot detect any monoclonals in the biopsy, elderly patients with C3 and thrombotic microangiopathy should also be investigated for monoclonal deposits. This was a nice picture, all by EM, just to again remind you, as we started this talk today, that it all depends on the characteristics of the light chains and how they are absorbed inside the cells, and how this is what you will end up with, either with amyloidosis, with fibrillary, with immunotactoid, with cryoglobulin. Here are all the types of organized deposits, or you will have the crystals, where you get the light chain proximal tubulopathy, crystal storing histiocytosis in the interstitium or in the glomeruli, or where you get the granular deposits like in monoclonal immunoglobulin deposition disease, or where you get it associated with immune complexes like in proliferative glomerulonephritis with all these nice subendothelial deposits, or in C3 glomerulonephritis only, where you get the subepithelial humps, or rarely in dense deposit disease. And this that I have mentioned also in the C3GN, that dense deposit disease is not a disease of only children, and that you can get dense deposit disease in the elderly. What do? You do a kidney biopsy. You need to have clinical suspicion. If you have light chain restriction on the immunohistochemistry study, you do serum and urine monoclonal studies, PEP immunofixation, free light chains, bone marrow aspirate and biopsy, and lymph node biopsy if the bone marrow is negative. And if the C3 are predominant deposits plus a monoclonal gammopathy, you can look for alteration in the complement pathway. So my take-home messages are that there are several mechanisms by which monoclonal immunoglobulins cause renal injury. As I have shown you for the past 2 hours, and I'm sorry, I know it was very long, but they have different characters, different mechanisms, different sites of injury, and hence so many different morphology and clinical presentation, and the pattern of which depends on the location of deposits in the kidney, how your patient is going to present. Please remember that they are not always isolated entities. You have light chain caused nephropathy with AL amyloidosis. They are commonly superimposed on systemic diseases, on diabetes, severe hypertension. They can change their phenotype. Patients can start with light chain caused nephropathy, then they deposit MIDD or amyloid, and they are not limited to old age. Finally, this varied, inconsistent clinical, hematological, laboratory, and renal pathology findings, particularly in older individuals, warrants a high degree of suspicion, adequate lab workup, and detailed tissue examination to make an accurate and timely diagnosis. And timely diagnosis makes a difference. you need to be suspicious of these diseases. Simply, you need to have them in mind. Otherwise, you're going to miss them. Early diagnosis saves lives, not only kidneys. So there is nothing wrong to be suspicious when we are considering monoclonal gammopathies. Thank you.
يعني احنا بنسقف يا دكتور وسام، يعني ساعتين وربع ما حسناش بهم. اعتقد ان المونوكلونال جاموباثي اوف رينال سيجنيفيكانس بقى موضوع كريستال كلير، لا يمكن ابدا يتوضح ولا يتبسط يعني الا يعني بوجود حد يعني قدير زي الدكتور وسام. احنا استمتعنا جدا، ولو في اي تعليق انا ناخده في دقيقه او دقيقتين. في اي حد عاوز يعلق؟ دكتوره دولت لو معانا عاوزه تعلق اتفضلي.
waiting for the amyloid on Friday بقى.
الاميلويد دكتوره وسام عامله في شغل جامد يعني، وانا فيري براود بالطيب اللي هو الجديد اللي هي طلعته بنسبه مش قليله. هنشوفها بقى عشان ما يلحقش المفاجاه المره الجايه ان شاء الله.
ان شاء الله.
والاميلويد فعلا يستاهل يتحط لوحده، لانه طبعا في كلام كتير
في كلام كتير عشان كده مش عايزين نعمل.
احنا
طيب اتمنى ما نكونش صدعناكم وان
لا بالعكس ده احنا يعني الكلام يعجز عن الابريشيشن والله يا دكتوره وسام. ونتمنى ان نشوف سعادتك ان شاء الله في يوم الجمعه ان شاء الله على خير
باذن الله.
وتصبحوا جميعا على خير، والسلام عليكم ورحمه الله وبركاته. مع الف سلامه.